This talk is about diffusion tensor imaging for cubital tunnel syndrome. It's the second most common compressive neuropathy, affecting 6% of the population. The symptoms are variable, but the majority of patients complain of dysesthesia in the ulnar half of the hand, and some anesthesia. If left long enough, the small muscles of the hand and some in the forearm atrophy, and the hand can adopt a clawed position and become disabled for fine tasks. The only reliable treatment is surgical decompression of the ulnar nerve. We do this very commonly, around 15,000 times a year in the UK and the USA. It involves decompressing this, which is the ulnar nerve, at the level of the funny bone, as well as a little way towards the armpit and a little way into the forearm. The problem is, as surgeons, we're not very good at selecting patients for this because ostensibly metadata shows that 13% of patients don't get better, and moreover, 3% develop serious complications. This is perhaps due to the fact that we have no diagnostic test for cubital tunnel syndrome, and this might be where DTI comes in. So we know that the diffusion of water within healthy versus unhealthy nerves is different. Healthy nerves, or axons or neurons, are wrapped in abundant and thick myelin and tightly bound together. Consequently, the diffusion of water within these fibers is highly ordered. It moves in a largely bidirectional fashion up and down the nerve. In unhealthy nerves, whatever the disease process, there are common morphological changes. 1, demyelination, with or without poor remyelination. The effect of that is the fibers are now more porous to water. Secondarily, there is perineural and epinural fibrosis, which means that the fibers are more widely spaced apart. This means that the diffusion is less directional in unhealthy nerves. In cross-section, we see that healthy nerves are very tightly bound together. The fibers are very tightly bound together, and as such, diffusion in this axis is slow and highly restricted, whereas unhealthy nerves have an abundance of connective tissue around the axons, and as such, diffusion is less restricted and faster. We sought to explore this hypothesis in cubital tunnel syndrome by scanning healthy adults and those awaiting surgery for cubital tunnel syndrome. We acquired DTI from the level of the elbow with the below details, and having acquired the data in opposing phase encoding directions, we took advantage of the full suite of corrections available in the FSL library. The data was then reconstructed using GQI and resampled to the space of T2, and here's what we got. On the T2 images at the level of the arm, cubital tunnel or forearm, we don't see peripheral nerves, that's normal. But here on the diffusion weighted imaging, this is an NQA map, we see peripheral nerves, median, ulnar and radial at the different levels in the limb. And we can extract diffusion metrics from these structures to demonstrate that healthy adults have a significantly higher fractional anisotropy throughout the length of the arm. Consider this. These are measurements from high up in the arm, at the level of the cubital tunnel where the problem is supposed to be, and within the forearm. Each point represents a measurement from a slice. Here, patients are around 10% lower in FA than healthy adults. We also discovered differences in radial diffusivity, whereby healthy asymptomatic adults had a fairly flat RD throughout the length of the arm, whereas patients had a substantially higher RD distal to the cubital tunnel, and in fact proximal to the level of the pathology. This is potentially really important for us as surgeons, because DTI appears to give objective evidence of the health of peripheral nerves, which is currently not provided by any other test, such as neurophysiology or ultrasound. Therefore, we believe we can use DTI to help us diagnose problems like cubital tunnel syndrome, or at least help in cases where the diagnosis is unclear. Furthermore, and uniquely, DTI could be used for the postoperative surveillance of peripheral nerves. I want to say a huge thank you to my co-authors and all those who supported this research. And if you'd like to get in touch, my contact details are below.